Welcome, everybody. My name is Marty Mascari. I'm with the North Central Texas Area Agency on Aging and the North Central Texas Aging and Disability Resource Center, or ADRC. The ADRC is a project under the Area Agency on Aging, and the North Central Texas Area Agency on Aging is under the umbrella of the North Central Texas Council of Governments. We're here today with Dr. Mottern to once again for a great webinar to talk about borderline personality disorder, the causes, the treatments, and how loved ones can help. And we've had a huge response, so thank you all for joining us. But before we get started, I'm going to talk a little bit about the CEUs. For those of you that are joining us today for CEUs, we are offering 1.5 hours of CEU or classroom credits for licensed social workers and licensed professional counselors licensed in Texas. For those of you that have other licenses in Texas or are licensed outside the state, you're more than welcome to go through the process and get a certificate. I've had people in these areas tell me that they've been able to use it, but there's no guarantee. We're set up with the state of Texas, but again, you're more than welcome to go through the process and get it and submit it, but it's up to your jurisdiction whether they'll take it. You also can get a certificate of attendance if you'd like. Those are available as well, and the rules for that are the same. You must complete the entire webinar live in order to qualify. You can't miss more than about 5 or 10 minutes of the entire webinar. You must also complete the Google survey evaluation. It will pop up as you close out of today's webinar. Zoom is set up for it to pop up, but I realize some of the companies that you work for, your computers have pop-up blockers. I know most of the people are able to get it, but if you're not, no worry. We will also send that out in a follow-up email after today's webinar. The Google survey evaluation will be up for 1 week until 5 o'clock next Wednesday, and give us 2 weeks after that to get the certificates out to you. And so that being said, I'd like to introduce the doctor, if we can move to the next one. Dr. Mottern is the Executive Director of the Mottern Institute for Mind, Body, and Wellness. He has 22 years of experience of in-person and worldwide virtual treatment in cognitive restructuring, behavioral modification, emotional regulation, and physical improvement. He's a published author of Living Well, A Guide to Cognitive Behavioral Skill Exercises, and that's available on Amazon, I know, because I purchased it, but you can also contact Dr. Mottern if you have any questions about that. So that being said, I'm going to turn it over to you, Doctor.
Thank you. Thank you. Always a pleasure to be here. Yes, I just got a royalty check for from Amazon for 6 cents. So yeah, that's putting that in my retirement fund. Okay. All right. Anyway, today, borderline personality disorder. This is a topic that generates a lot of interest because it's so striking when you deal with it, when you have to deal with that. So, and I'm sure it is when you live with it as well. But for those of us who treat it and deal with it in a treatment setting, it also becomes very memorable. So today, what are we going to look at? Well, what is borderline personality disorder? We want to look at the DSM-5-TR characteristics for that, for the diagnosis for that, what you do as treatment for that. We'll look at dialectic behavior therapy, DBT, some pharmacology. Remember, the pharmacology, it doesn't treat the disorder itself. It treats sort of co-occurring things that, symptomatic, that are symptomatic for it. It's going to be another one of those days with my talking, I'm afraid. Then we want to look at borderline in popular culture. There's a few things out there that we can look at. Then how loved ones can help. So that's where we're going today. And so, what is borderline personality disorder? Traditionally, borderline gets its name because it's on the borderline between neuroses and psychoses. Now, neuroses is a term that we don't use much in psychology anymore. The psychoses part we covered not too long ago in a presentation when we were here. But the best definition of those I probably ever heard was from my first psychology teacher. He was a psychiatrist down in Galveston, And he said that neurotics build castles in the air while psychotics live in them, which is a pretty good definition, pretty good working definition of those two things. And it's a really good definition of borderline, because when somebody gets that diagnosis of borderline, what they do is they create these, these neurotic ideas in their head, these anxious ideas, these things that they get in their head, and then they act like they're true, whether they, whether they know they are or not. Now, the difference between that and a psychotic would have hallucinations or delusions or what have you that actually made it true to them. In this case, it's just they're worried about this. They have these neuroses going on, this anxiety about whatever it is, but then they let the thinking get carried away and act as if that thinking is actually true without anything to back it up, really. Okay, so borderline is characterized by marked instability in functioning, okay? Affect, mood, interpersonal relationships, and at times reality testing. This is one of the biggest things, and when we get to the diagnosis, you'll see this, these intense interpersonal relationships that go on. This is sort of characteristic of borderline. Patients with the borderline may manifest overwhelming anger when they're in a state of crisis. This is how do we deal with these? How do I deal with crises? I get angry. I used to work in a community-based correctional facility close to here, and the intake coordinator, I used to joke with her that she would only put people on my caseload if they had 150% chance of recidivism and were borderline. and they would often describe these people who came in as having their hair on fire. Okay, that used to be, so the overwhelming anger whenever they're in a crisis, okay, then that's, the hair on fire thing. That's a good thing to look for. Has some psychotic symptoms, but those are generally short-lived, okay. Good reality testing that goes along with those. They can tell what's real and what isn't, right? So if they're there, they're just very fleeting, okay. Individuals with personality disorders in general frequently dissatisfied with social, occupational, or academic functioning. In fact, once again, as we look at the diagnosis of this, that's sort of what characterizes any pathology, right? If it's not causing me disorders in my social life or occupational life or my academic life or something like that, then it's not really a problem, okay? We probably don't need to diagnose anything at that point. We may have symptoms of these things, but they may not get a pure diagnosis for that. So that's another thing to look at. A lot of times people have symptoms of these different things. And we've covered that under different presentations that we've done here, that just because I have the symptom of this, it seems to be a symptom of this, doesn't mean that this is going to get a diagnosis. So I may have people that are easily triggered to get their hair on fire and what have you. That doesn't mean that they're borderline, okay? There's other things that go with it that we'll look at in just a second. But I just always want to throw that in there because when I started work at this community-based correctional facility for substance abusing offenders, felony offenders, we had a psychiatrist who was over that program, that treatment aspect of the program, and he used to always remind us that the people you're seeing are not true cases of whatever it is you may be think you're looking at. So borderline, may have some characteristics there, but they're not true borderlines, because the people who are 100% get this diagnosis are probably in the state hospital. Okay, so now that being said, like I said, we had our share of borderline personality disorder manifested itself there, and I usually got those. So joy to me. The features of borderline personality typically show up in adolescence or young adulthood. And by the time about 30, 40 years old, those things seem to calm down a little bit if the person lives that long, okay? Borderline personality disorder is one of the only, if not the only, it used to be the only, I haven't finished reading completely the new DSM-5-TR, so I'm not sure if they changed anything on there. But used to, it was the only diagnosis which carried with it one of the diagnostic characteristics was suicide and self-harm. So that suicidal ideation, those suicide attempts, often prevent people with borderline from living to 30 or 40 years old, to where those symptoms sort of seem to calm down. Now, why do they calm down? Well, probably because at that point in life, I've learned to deal with things in a different way, right? Whereas if I, adolescence, young adulthood, I'm just experiencing the world. I have some experience under my belt, but I haven't experienced the wide world as I'll, will have done when I'm 30 or 40 years old. So, yeah, that's there. Unstable sense of self with poor ability for self-direction. And this is an impaired ability to pursue meaningful short-term goals. This is why oftentimes in something like dialectic behavior therapy, we'll see goal setting as part of that, right? So that sort of therapy addresses these things. We'll talk more about that. We'll get into it a little more as we look, but that's the reason those things show up, because I find it very difficult to achieve those short-term goals, find any self-direction, all of which, let me just point out immediately, that all of which is because of the thinking that goes on, is the cognitive stuff that goes on. So for something like DBT, dialectic behavior therapy, it's a form of cognitive behavioral therapy, a lot of cognitive work going on in those, being able to restructure things, being able to recognize thinking errors, cognitive errors, and then correct those and what have you. Once again, those cognitive errors are what I think is this, I think this is happening, and then I'm going to act like it's real, even though it's a cognitive error. So being able to correct those is very important. Disturbances in empathy and intimacy. Once again, those intense interpersonal relationships that go from you're the greatest person in the world to you are a piece of trash, okay? And within 10 minutes, okay? You're the greatest counselor in the world to you are not worth my time to even talk to, okay? So let me also say, for those of you who may be doing it for CEUs or whatever, that if you have to work with DBT, if you have to work with borderline, it used to be considered therapeutically irresponsible to treat borderline personality in isolation, which means that borderline personality is best treated in a group setting. And by group, I mean a group of counselors, not a group of other borderlines. Okay. Some people do it in isolation, but that's not the best thing. Used to be considered, once again, therapeutically irresponsible to try to do it. And I'll give you an example of that as we move forward. Okay, a pattern of impulsivity, risk-taking. This can also tie into the suicidal behavior and poor self-image. As far as the prevalence of borderline goes, we see it 6% of primary care settings, you'll see borderline personality, 10% of people who are in outpatient mental health clinics, and then 20% among psychiatric patients. So that's sort of the prevalence of that there. We used to think that more women than men exhibited with borderline, but what we're finding out now is that it's 50-50. There's really no difference between the two. It'll show up in men just as well as it will for women. Just as a side note, antisocial personality disorder, men are typically more likely to be diagnosed with antisocial personality disorder, while women, even though they may be antisocial, are diagnosed with borderline. So there's some problems with diagnosis there oftentimes. Okay, borderline occurs with many other things. Depressive, bipolar, substance use disorders especially, which may also tie into the suicide stuff, self-harm and what have you. Anxiety disorders looks like some of those. Eating disorders, notably bulimia, okay, and binge eating. And once again, this is something I'll talk a little bit about later on because it shows up in an interesting place. And then It also occurs with the other cluster B personality disorders as well. So, it's something that's out there that's fairly common, and when we have to deal with this. So, how do we diagnose it? What's the DSM say about it? Once again, pervasive, okay, pattern of instability of interpersonal relationship, self-image, and affect. Okay, so that these severe interpersonal relationship crises, okay, that go on pervasively throughout their life with their family, with their friends, should they have many of them, with people at work, with people on the street, okay, people in the grocery store. Okay, these sorts of things are sort of characteristic of borderline personality. Also, marked impulsivity, okay, poor impulse control, instant gratification, begins once again early adulthood, and these things evidence themselves in at least 5 or more of the following. Okay, frantic efforts to avoid real or imagined abandonment. Okay, now this is one of those things where you have someone who engages in intense interpersonal conflict with other people. And then when other people back off, say, I've really had enough of this. If you're in a therapeutic situation, I'm really having some counter transference go on here. I think maybe we should have you move to another therapist. Oh, you're abandoning me, right? Or the same thing even with family, right? Our families can put up with a lot. Our families do put up with a lot, right? But at some point, even families will say, you know what, enough. I've had enough of it. At that point, oh, you're abandoning me. Everybody abandons me. What's difficult for them to realize is that their way of interrelating with people is what causes other people to want to abandon them, right? want to back off. So they sort of create their own problem, right? They create that problem in the way they relate to other people. And then when other people abandon them, it's, oh, I'm always being abandoned. So I'm trying to avoid that. And the way they try to avoid it is you're the best, right? That's where we go to the other end. Borderline personality, one of the thinking errors, one of the cognitive distortions that we see often is black and white thinking, that dichotomous thinking, okay? All or nothing thinking, whatever you want to call it. Okay, we see that often, and that's what happens. How do I avoid abandonment? Well, you're the best thing in the world, right? And I'm not going to leave you if I think you're the best thing in the world. But then what happens? Something goes awry. I disagree with you on something, and then all of a sudden I'm trash. Once again, I'm worth nothing. My opinion is useless, and because my opinion is useless, then I don't want to be around you anymore. Okay, once I get so much of that, that's enough. I can't take it anymore, and so I create that dynamic of I set people up to be the best, and then they're the worst. And after so much of that, support, push me, pull you stuff, people tend to back off. So I actually create the abandonment that I fear. Okay, which is a very difficult place to be when I'm creating the very thing that I'm afraid of. Okay. Number 2, pattern of unstable and intense interpersonal relationships, extremes of idealization, devaluation. That's just what I was talking about, right? Number 3, identity disturbance, markedly and persistently unstable self-image or sense of self. Who am I? Okay, what is my place? What do I do in the world? Okay, that self-image I have, that sense of self that I have, not very sound. Okay. It seems like that changes a lot. I don't have a good solid base on this is who I am and what have you. Impulsivity in at least 2 areas that are potentially self-damaging. This ties into number 5, which is the suicidal behavior and what have you. Spending, sex, substance abuse, reckless driving, binge eating. Okay. Now notice these, if I'm going to put that criteria, I can't use it as number 5, but how it often shows up is as a form of suicidal behavior. Once again, especially in substance abuse, right? That people use and keep on using until, the progression of that is jails, institutions, and death, right? So they keep that up even though they're at they've been in institutions and may have even come close to dying before, but they continue to do that. Okay. Now we'll talk more about substance abuse at a later time, but that's one of the ways that it shows up. Once again, if I'm going to use it as a criterion 4, I can't use it for both 4 and 5, but it often shows up in 5. Sex will often also show up that way. So unprotected sex, promiscuous unprotected sex. These are things where this will show up over and over. I remember in the treatment facility I was at, we had a person in there who was definitely a young woman who was definitely diagnosed as borderline, and that's what got her out of the facility. And when I say out of the facility, I mean she was returned to incarceration because she was engaging in sexual activity in the place, which was forbidden. Because if you're thinking of, it was a treatment facility, once again, for substance abuse, if you're thinking about sex, you're not thinking about treatment. And that's made very clear to people who were there. She continued to engage in that. So she left, went back to jail. Also, other people did who were involved in that. And she had some other situations in her life on the same thing, on the same looking at sex as a self-harming behavior, as a potentially suicidal behavior, especially at this time where I'm talking about, these days we have with something like HIV, with something like AIDS. I know people who have, who've had that and for going on 20 years, who have had that going on 20 years now. And they're able to live and have a fairly good quality of life because of the drugs that we have now, because of the medications that we have. Before that, however, that was not a good thing to get. I mean, it's still not good. Okay, just because you're living and can have a fairly good quality of life doesn't mean it's the same as not having it, the quality of life you could have. But prior to that, almost during those times when we didn't know a whole lot about those diseases and what have you, it was almost a death sentence to get those, and to go around having not only promiscuous sex but unprotected sex was courting disaster. It was almost a suicidal behavior there, and that was certainly some stuff that she was involved in. Number 5, reoccurrent suicidal behaviors, gestures, or threats, or self-mutilating behavior. So once again, this is where, and like I said, I haven't completed reading the whole DSM-5-TR, but this criteria right here used to be the only one that had it was borderline. Okay, it was a diagnostic criteria for borderline, and the survival rate for borderline was very low. Okay, most did not reach that 30 or 40 where things seem to drop, but seem to be able to cope with things better, pick up some more life skills. So very dangerous one, and continues to be. Number 6, affective instability due to a marked reactivity of mood. Okay, this is the hair on fire stuff, right? Intense episodic dysphoria, irritability, anxiety, usually lasts a few hours, rarely more than a few days. Once again, they go from one pole to the other, right? From one pole to the other. So it's that you sort of, when you get that sort of push me, pull you thing, you sort of look at those, them going from one pole to the other. That's pretty characteristic of that. If you work with any population, you get to know them pretty well. But if you spend a lot of time working with borderlines, then that's something that you'll see, that black and white stuff, that from one pole to the other stuff. Number 7, chronic feelings of emptiness. Well, we know if you've been with us before when we've talked about choice theory psychology and reality therapy, which I'm a proponent of, that Glasser says that all long-term psychiatric problems in our life are relationship problems, right? And when I have this relationship, these intense interpersonal relationships where I'm pushing people away all the time, guess what's going to come of that? These feelings of emptiness. And what else comes of that? Suicidal ideation, right? So this is a pattern of thinking and behavior that really causes the person many problems. It's a negative feedback loop. and it just keeps getting worse. And unfortunately, that's the reason we see such a high percentage of suicides there. Number 8, inappropriate, intense anger or difficulty controlling anger. There's a way we look at, power thrust is one of the things, and anger gets in there as using anger as a weapon. Okay, not just anger, but using anger as a weapon. And that's really what shows up in borderline, where I use this anger against other people. I use it as a weapon in the recurrent physical fights that may go on as well that are there. These are what show up. Transient stress-related paranoid ideation or severe dissociative symptoms. Once again, these things can occur. They're generally transitory. They're not going to last very long when they do, but they do show up. So there we have the diagnostic criteria for that. And remember, it's 5 or more of any of those. And now, so what do we do? So what do we do about that? How do I help somebody who has this? What do we do? Well, in formal treatment, dialectic behavior therapy, DBT, is the only thing that has sort of a research base to support it. Okay, it's the only data supported treatment is for borderline personality disorder is DBT. Okay, it's a modified cognitive behavioral stuff. Okay, so I've had some training on DBT, and I find I really don't see anything there that's not in a normal practice in cognitive behavioral therapy, especially if you're using cognitive behavioral skills that include mindfulness and things like that. Then it's sort of the same thing that you're gonna see. They have some interesting tools. We'll look at some of those in a minute, but it's cognitive behavioral therapy. Okay, with a different sort of slant. Okay, different sort of slant. For children and adolescents who have these borderline traits, family-oriented interventions can have some benefits to them. But remember, this is for children and adolescents. By the time they get to adulthood, those family patterns have already formed. Okay. You have family systems therapy. That would be something that you would have to try to do. Okay. Once somebody is an adult, I've already developed these patterns, these set patterns of the way I interact with the people around me, and that includes my family. And the family has also developed ways that they interact with me. Those of you who have done, family therapy treatment, who've done that treatment, know how difficult that can be outside of something like borderline, right? Just in a normal situation, somebody is, having some problems with anxiety or stress in their life. So you call the family in. Boy, once you get started working with the family, you realize that, your client may not be the only one who needs some treatment, right? And this is what shows up, especially with borderline. And it's not because there's anything inherently wrong, except that everybody has fallen into their ways of doing something different. This is oftentimes what you see with substance abuse. Let me just say that is that the addict, the substance abuser, has done that for so long that their family has learned to treat them in a certain way. So when they become clean and sober and try to change their life, the family is still going to treat them like they're a user. Okay, because that's what the addict has trained the family to do over the years. Not the family's fault. That's just how they've been trained. Same thing with borderline. Okay, the borderline has trained their family to deal with them in a certain way, and it makes it very difficult to change outside of some kind of family systems therapy when you do that. And when I say family systems theory, I mean everybody is in therapy. Okay, I don't mean the family just shows up for a session or two to talk a few things out like you would do in regular, have a family session or something like that. But family systems therapy, you break down the family systems and everybody comes in and everybody has to learn to be different. One of the things that's so hard about that is if you're a part of the family, you're saying, why do I have to go in? I'm not the one with the problem, right? I'm not the one who's dealing with this. You got to deal with this. if you want to be supportive of somebody who, then that's something you'll engage in. But you may feel, and rightly so, you may feel that you've done enough and you don't want to do any more. But that's what it takes to break it as an adult. So the sooner you can get them, the better it is. For children, adolescents, there's still some, we can still, those patterns haven't become set in concrete with the family. We can do some family oriented stuff and get some good benefit out of that. Most children and adolescents with traits of borderline appear to benefit from structured programs, structured day programs, strong behavioral management components. When I was in that treatment facility and I asked the intake coordinator, why do you give me these people? Okay, what is it? Why is it? Can't I have just a normal, schizophrenic or something like that? She said, because you're so good at setting boundaries. Okay, and that's a lot. That has a lot of it. That if you're struggling with borderline personality disorder, if you want to help somebody with that, then you have to set boundaries. It has to have a lot of structure, okay, and some strong behavioral management stuff to go along with that. So with children and adolescents, that's what they want to use. And so that's what we provide. Okay, is that lots of structure. Okay, because once again, structure. I know this may sound strange, but structure. If I'm in treatment, structure helps me feel safe. Okay, because I know what's going to happen. I know there's choices and consequences. I know if I make this choice, I'm going to get this consequence. Okay, I know it. Okay, and that, in a way, helps me feel safe, and nobody is going to change if they don't feel safe. If I don't feel safe in a situation, I'm not going to do anything different. That's just flat out the way it is. Okay, and that's nobody is going to be doing anything different if they don't feel safe, because the way they've developed, the behaviors they've developed, the thinking they've developed, helps them feel safe in the situation, helps them feel in control of the situation on a daily basis. So I'm not going to change that. Even though it may be hurtful for me in the long term, I'm not going to change that if I don't feel safe. So especially for children and adolescents, developing that structure that helps them to feel safe so that then you can work on change. Okay. Now, by the time they're adults in this, if they're fortunate enough to live that long, then, and I'm not, and I say that, and I don't mean that, that the majority of people are going to commit suicide, but a significant number do. Okay, that's the reason suicide is considered one of the diagnostic characteristics. But by the time they get to be an adult, and there's an old saying: it's hard to teach an old dog new tricks, right? Sometimes that's true, sometimes it's not true. With this, it tends to be truer. Okay, so once again, dialectic behavior therapy. Also, you'll also hear this called dialectical behavior therapy. And the reason it's called dialectic behavior therapy, the dialectic exists between thesis and antithesis. This is the black and white thinking that's so common, right? You have thesis, you have antithesis, and what we want to do is we want to create a gray area there. That's synthesis. Okay, you have thesis, you have antithesis. We want a synthesis of that. Okay, so they're either got their hair on fire or they're not interested at all, completely withdrawn. Okay, well, what we want to do is we want to create a gray area there. We want to get people comfortable with looking at gray, which is very difficult with people with borderline. Okay, it's one way or the other. It's all or nothing. So getting them comfortable with that gray area. How do you do that? Well, there's some skills that you can use. Mindfulness is one of the skills. Okay, we've practiced some of that here in the past, but that's a good skill to have. Helps us calm down, helps us pay attention to our thinking. Okay, once again, remember this is cognitive behavioral therapy, so we're going to pay a lot of attention to the thinking that's going on as we go through these things. So that mindfulness helps me slow down. And when I slow down, when I relax, when I calm down, then I can start to pay attention to my thinking, which is step number one in cognitive self-change, right? Is to pay attention to my thinking. So the mindfulness can help with that. Another area of it is emotion regulation. Okay, I want to regulate those emotions, and remember that emotions are caused by my thinking. Okay, we do not have predetermined emotional tracts built into us. Sorry, we just don't have it. There's no research that ever showed it, okay, or that shows it now. In fact, it shows exactly the opposite. So, I mean, we have basic emotions as children, the ability to self-soothe, the ability to frustrate, things like that. But any emotion we experience longer than 15 seconds is, we're creating that with our thinking. And now that thinking, let me just, I'm not saying we're consciously creating it with that thinking. We've done it so much from the time we were born that we do that on a unconscious basis. You know, the first thing we learn to do as children is to anger. Okay, I mean, you know, we're in the womb and we have this tube and we're fed with it and we're warm and everything's great. And then somebody cuts off the tube and we're out and it's cold and it's harsh and somebody's slapping me. And then after a while, because I don't have that feeding tube anymore, you know, that umbilical, right? Then I start to get hungry. I have this sensation inside of me that causes me pain. And so what do? I cry, and I cry until until somebody feeds me. That means I cry and I yell and I scream. I anger in essence, okay, until somebody does that. The second thing we learn to do as children is depress, right? So at some point, our parents catch on to the fact that, you know, he doesn't really need any more food, so we're just going to let him scream. And so then what do I learn to do? I scream and scream and scream, and they don't do anything for me, and then I begin to pout, right? So anger and depress are the first two things we learn how to do. Okay, but unfortunately, some people don't go sort of beyond that. Okay, so we have to learn to regulate those emotions. We have to regulate the thinking that causes those emotions to actually occur. So once more, back to the cognitive stuff. Distress tolerance, that's also part of the stuff that we want to look at in DBT. And then interpersonal effectiveness, okay? Remember, those intense interpersonal conflicts are characteristic of borderline. So what do I want to do? I want to learn some social skills on how to be effective in my interpersonal relationships. Okay. All right. So for the mindfulness part, okay, these are some of the techniques that they teach in DBT as a part of the mindfulness. Now, there's more than this. This is just a sample of them, okay? One is simply observing. And that's start to develop the mindfulness skills by observing a single object. Just sit and look at a leaf on a tree, sit and look at a blade of grass, sit and look at a spot on the wall. Okay, it doesn't matter. I'm just sitting and doing that. Now, invariably, what you will find, even with people who don't have DBT, right? I mean, even if people who don't have borderline, is that when I try to focus on something, my mind is going to go off onto something else, right? So how I learn mindfulness is as my mind goes off, I pull it back. And as it goes off, I pull it back. And as it goes off, I pull it back. And over time, as with all skills, then what I learn to do is I'm able to hold my concentration longer, and it takes less time to pull it back. So that's just this simply observing things, observing whatever it is. It doesn't matter what it is, but it's just one object, okay? Single object that I'm going to focus on and pay attention to it. And when I catch myself thinking about something else, I pull it back to that object. Mental body scan is another. Learn to relax your body, strengthen the mind-body connection. This is a sort of a progressive relaxation exercise that you can do, okay? Many ways to do that. Find one that works for you, but using that mental body scan is something that will help. Once again, helps me to calm down. I'm using some mindfulness because I'm focusing on my body, right? I'm focusing on this. I may visualize that there's like a supermarket scanner that's going down and everything above the scanner is relaxed and calm and peaceful. But sort of a progressive relaxation exercise that gets me paying attention to my body, which may be helpful later on in the emotional control aspects as well. Internal and external is an exercise where we sort of examine, is my orientation more internal? Am I focused more on external events? Which one do I tend to focus on the most? And then how do I create balance? Once again, we have thesis, antithesis, we want synthesis, okay? So we don't want it to be entirely internal, don't want to be entirely external. We need to find a balance between the two. That's what DBT teaches, is that balance, right? Describe your emotions. Oftentimes people have a very difficult time describing their emotions. When I teach cognitive restructuring, I'll ask, what are you feeling emotionally? What's going on with you? And they start giving me thoughts, okay, which are not emotions. Emotions are one word. You got to use more than one word. It's not an emotion, okay? So they'll talk, they'll go on and on, which I'll just list under the thoughts. Okay, great. We'll just put those under thoughts. But what are you feeling related to that thought? What emotion relates to that particular thought? And then how do you describe that? Once again, many people, what does it feel like to be angry? What's it feel like to be frustrated? What's it feel like to be excited? Okay. So, and these are often the same thing. What does it feel like to be anxious? Okay. What's the difference between anxiety, fear, and other things, right? Well, it may be simply the way that I mentally look at it, because physiologically the same thing's going on. Okay, whether I'm excited, whether I'm anxious, whether I'm afraid, physically, same things are going on. So the difference is the mental aspects, but I have to be able to describe what emotion am I feeling has value as well. Mental noting, becoming more aware of my thoughts and emotions. Once again, this is part of cognitive restructuring, right? Step number one of cognitive restructuring, pay attention to my thoughts and feelings. Step two, recognize risk in my thoughts and feelings. And then step number three, replace the risk thinking with new thinking that reduces the risk. So you'll see how all of these things in DBT, at least at this area, sort of relate back to why it's a part of cognitive behavioral therapy, because we're doing cognitive restructuring as we go on. We are working on behavioral skills as well, as we'll see when we're working with DBT. Okay, emotional regulation, recognizing your emotions. Once again, recognizes those primary emotions and the secondary emotions that follow from it. This is a particular exercise that they use. You can use this in what they call a chain exercise. But, I recognize the emotion I'm having, but what emotion caused that? And sort of follow back the chain, right? What emotion caused that emotion, and what caused that? And then we can look at the thinking that caused that to begin with. Being effective, setting goals, creating an action plan in order to be able to reach these goals. Remember that borderline personality disorder is sort of characterized by that inability to set goals, right? I don't know how to goal set. Goal setting is a skill. And this is what we found in something also, just to deviate off topic a little bit, but this is something that we found in antisocial personality disorder, in that treatment, is that somewhere along the line, those common sense goal setting skills that most of us got, those people didn't get. So if we want to change what's going on with it, we have to teach them those skills. And it's sort of the same thing with borderline. Okay. Somewhere along the way, they didn't pick up how to create goals. They didn't pick up how to create an action plan in order to achieve those goals. So we have to teach that to them. Okay, it's a skill. It's a skill. They can learn. They can grow. Okay, emotions and physical vulnerability. See how your habits influence your well-being. Okay, looking at that. What do I do that causes this, right? And I get to this point, and I don't want to be at this point. This is a bad point for me, but what did I do that sort of got me there, and that habit, and how can I change that? And oftentimes really paying attention as well to physically what's going on there, what's going on that I'm tying into that physical vulnerability, okay? What's going on with me physically that causes me to go this way. And this is something that I can learn to pick up with, that I mentioned before. I can pick it up on a physical level. I notice that when I feel cold, for example, I know that I am getting ready to do something that is not going to be good, okay? Why? Because when I feel cold, I'm in fight or flight. The blood has drained out of my extremities to the core of my body. I'm able to recognize that, and I also recognize that I'm getting ready to do something drastic. So being able to pick up physically on things like that, physically, I'm starting to feel cold. I need to take a step back. I need to look at my thinking, change my perspective of what's going on. Same thing with the cognition, right? Do the same thing with the cognition. Some people are more cognitively oriented than other people. So being able to look at my thinking when I have this particular thought, boy, I know that's a risk thought for me. So I need to step back, or I'm going to do something that I shouldn't do. So paying attention not only to what's going on in the thinking, but physically what's going on in the body as well, as related to the emotions. And then self-validation, accept the emotions. There's emotions. I have this emotion, and I have it because of my thinking. Okay. And if I want to change it, then I can change my thinking to get there. But right now, this is what I'm feeling. Distress tolerance is another one. Remember, once again, that people with borderline personality disorder are very impulsive, right? And so what do we have to, how do we correct impulsivity? Distress tolerance, right? That's how we do it. I get used to dealing with this frustration longer. Okay, is what it is. Sometimes we all need a little bit of that, right? Sometimes I have, especially when we get in our cars and are on the roads around here, have to distress tolerance. Okay, get that. A lot of thinking errors involved in this distress tolerance that I want to look at. One thing that I can do is a cost benefit analysis. Once again, this is a form of problem solving. Okay, the cost benefit analysis is a form of problem solving where I look at if I do this, what are the costs of this? If I do it, what are the benefits to it, and which one outweighs which, right? Okay, well, the benefits outweigh the costs. If I do this, great. Or the costs are going to outweigh any benefits that I'm going to get out of this. And then I just have to make a logical decision, right? Recognizing emotional crisis, learn to detect when an emotional crisis is starting. Once again, we see how this ties into being able to detect physically what may be going on with me, or mentally what may be going on with me that may tell me that an emotional crisis is brewing, right? So I want to catch that first, and then later on, I'll change that. Okay, but I want to catch it. I want to catch it first before it ever manifests itself. And that's what we see, right? When we try to learn and we try to change these things, people are learning, and they won't be able to catch themselves immediately. They'll just get there to that emotional state, and that's fine because that's where they are. But as they practice this, they'll be able to catch themselves sooner and sooner and sooner. And the quicker you can catch it, the quicker you can have an intervention there that you can apply to yourself. And then, I never get to that emotional part. So in my intense interpersonal relationships, right? Family, they say something that triggers me, right? Family's good at that, right? So they say that. So I know as soon as they say that, and I'm going to get there. But I catch myself before. Right? I have to just slow down my thinking. It's a difficult thing to do, okay? And it takes time to work on it, but it's what we have to do. It can be done, and that's what we have to do if we want to learn to change it. Come up with distracting activities. What's a distraction that I can use, okay? Mindfulness can be a distraction because mindfulness, I'm focusing just on whatever that one thing is, right? That one object. doing some progressive relaxation. That's what I'm focusing on. I'm distracting myself from whatever it is that's causing me the problem in the moment. Okay. Diaphragmatic breathing is a good thing. A lot of people use diaphragmatic breathing as a distraction activity. That's fine. You can do that. In stress management, we use it more for physiological, bringing about physiological changes in the body, but it can also be used as a distraction. So come up with a, I teach people to come up with a toolbox full of these things. When distracting activities, when you need those, what are you going to reach in and pull out to work on this? Then there's the resist technique. Is 7 techniques to help you deal with unhealthy urges during an emotional crisis. And then grounding, okay? Really reconnect. When I ground, I reconnect with the present. What's going on with me right now in the present moment, okay? I'm thinking about the past. I'm thinking about the future. It's not doing me any good to do that, okay? Because I'm going off on a tangent if I do. So I reconnect right now. One of the grounding techniques that we have is to, you can focus on if you're sitting down like I am right now, you can focus on what does my body feel like as it leans against the back of the chair? What do my legs feel like as they're sitting on the chair? What, my arms are on the chair arms. What is that? Just paying attention to that. Once again, sort of a form of mindfulness, but it grounds me right here, right now, as I'm sitting in the chair. So grounding is another technique to work with distress tolerance. Again, let me say, these are just a few of the techniques for each of these things. Different programs have many different more of these things that go on. Cognitive behavioral therapy has been around for a long time, and they draw from that. So these things have been around for a very long time, and there's a lot of them. Okay, so for the resist, when we're looking at those 7 techniques, right? This is what the resist stands for. Okay, I reframe the situation, immediately engaging in some cognitive restructuring, reframing this situation. So I may have someone who's struggling with borderline personality who is, pushed their boyfriend away. Their boyfriend no longer wants anything to do with them. So they're having those feelings of abandonment and all of this other stuff. And then they go back to I'm unlovable and nobody loves me and these sorts of things, these sorts of beliefs. And so reframe that, okay? Reframe the situation in some way. One way may be, at least you've known that. At least you've known love, right? At least you've had somebody who loves you right now. So you can reframe that in another way. Engage in a distracting activity. So I want to reframe the situation. I want to start that distraction, maybe the diaphragmatic breathing. I want to focus on somebody other than myself. When I'm in that state, I tend to wormhole, right? And I tend to wormhole just on me and what's going on with me. So focusing on, well, what's going on with them? They don't seem to be upset about this. So focusing on the other, focus on the intense sensations that I'm feeling, okay? And focus on them in an objective manner, okay? Shut it out. Use those techniques to shut these things out, the distraction techniques, the things I can use to shut out what's going on around me. Think neutral thoughts, okay? Once again, we're trying to get to gray, right? We're trying to, sometimes to get to gray, I have to go. Sometimes people say, I don't know what a gray thought is. Well, if I'm at, say, a black thought, right? It's a risky thought, a black thought. Then what would the exact opposite of that be? What would that's the white thought, right? Well, I don't really want to get to there, and it's unlikely that I'm going to get to there. But being able to say this is one pole and this is the other, then I can say what's in between, okay? So helping people realize, okay, if this is one pole, if this is where you are, what's the exact opposite of it? They're not going to get there, so you don't want to go there. But what's in between? What's the gray? What's the gray area? So think the neutral thoughts, and then take a break from it all. Okay, allow yourself to take a break. Okay, allow yourself to put that burden down. You don't have to deal with that. Is this an in-your-face problem? Feels like it. Borderline personality disorder often makes me want to think that every problem that I have in my life is an in-my-face problem. When 90% of the time they're not. 90% of the time they're time to think problems, right? I've got time to think about it. I don't have to deal with this right now. That's part of that emotional instability, right? That distress that I go under. I can't tolerate that distress. Got to get it to it right now. No, I don't. So I want to tell myself that. No, I don't have to deal with this. This is not an in-my-face problem. It's a time to think problem. I've got time to deal with this later. Right now, I'm just going to allow myself to do some diaphragmatic breathing, do a little mindfulness, do some mindfulness techniques, and take a break. So that's what the resist is for those 7 techniques. An example of that, I just put an example of that on here. You can, I'll let you read that. I'm not gonna go through it, but you can review that as we go through that. As far as interpersonal effectiveness goes, communication styles, identify your communication style to be more mindful of how you usually communicate. Okay, people with borderline personality often communicate very loudly. And this is, people think they're yelling at them, right? So I think somebody's yelling at me, I'm gonna react in a certain way. They don't realize that they're doing that. That's just how they communicate, right? So being able to come up, what's your communication style, and you can divide those up. Usually when we look at it, it's, am I a passive communicator? Am I aggressive? Am I passive aggressive communicator? Things like this, and realizing how that may or may not work for me, right? Usually not work for me in every situation. Sometimes it works for me. That's the reason I use it. But a lot of the times it doesn't. So learning some new skills, so how do you communicate? What is it that when you talk to people, they don't seem to be interested in you? Well, maybe it's because they think you're yelling at them a lot of the times. Okay, you're very loud and what have you. So that, just discover what that is. How does that work? Learn assertiveness. Okay. Once again, assertiveness is a gray area. Okay, it's not passive, it's not aggressive, it's assertive. So assertiveness is a gray area. So once again, it's not passive, it's not aggressive, it's assertive. Okay, and that's a skill. Being assertive is a skill that many people with borderline have a difficult time dealing with. That because once again, they want it either black or white. Have a hard time finding that gray area, but it's a skill. You can learn it and you can use it. Listening and validation. Learn to listen. Active listening is a skill, is a social skill, and it's an active listening is a skill that you need to learn if you're dealing with borderline, or that you need to teach if you're dealing with borderlines. Learning to actively listen to what the other person is saying. There's that sort of saying that goes, people don't usually listen to understand, they listen to respond. Okay, a friend of mine who does things, anytime he's talking to somebody and he sees their eyes sort of go up, he stops immediately because he knows that they're not listening to him anymore. They're formulating a response to whatever he has to say. Okay, so learn to teach people to listen to actually what is going on, and not only that, but what do they mean? Now, understanding and responding to the feelings of others, which requires that I listen to other people, is empathy, right? And remember that in borderline, you have a problem with that empathy, problem understanding and responding to the feelings of others, because I'm so focused, I'm so wormholed on me that I'm not looking outside of myself. So modulating intensity. Oh, this is, yeah, modulate the intensity, gear it down a little bit, talk in a voice that may be more low, not so high, right? Because we're, as human beings, we are sort of geared physiologically to, when we hear these high-pitched sounds, it means trouble for us. And so when somebody comes at you talking like that, you're like, well, what's I get anxious and I don't want to deal with it. Okay, so teaching people to lower that voice. If you lower it just an octave there, then you'll have a very different response for it. So modulating the intensity Even if you're using assertiveness, right, you need to do that in a way that doesn't seem aggressive. Okay, I'm being assertive in an aggressive way. You don't want to do that. Okay, so modulate that intensity. Resistance and conflict. I have to master the art of communicating effectively, even when somebody doesn't agree with me. And this is another one of those things, sort of characteristic, at least in the people that I've worked with, is that they have to be right. Okay, and they spend a lot of their time. And when I say right, I mean they want to be understood. But but underlying that is, if you understand me, you'll know that I'm right. So they spend a lot of time speaking loudly, arguing with other people to get them to see that they're right, and it's not going to happen. Okay, it's not going to happen. Not in the way that you're approaching it. But they will also tell me that as they use these skills, as they calm down, what they realize is that both people were actually saying the same thing. They'll tell me, I realized we were actually saying the same thing. We were just saying it in different ways. But when I get caught up in the moment, and when I'm trying to prove that I'm right, that I'm not listening to understand, I'm not, I'm responding. I'm just responding here. I'm not listening really. So the people who do this and are able to make these changes, I mean, I hear it all the time. This is something that is not, even though it is a personality disorder. Personality disorders are notoriously difficult to change, and this one is no different. I have seen people make extraordinary progress in this. The family is the hardest. The family part, that's the hardest. Work with family, that's the most difficult. But they can do it with other people. Okay, so more treatment. Psychotherapy is often difficult because people will relapse back into old behaviors, even though they once, they make these changes and what have you, and they tell me they work, and they see that they work. They'll relapse into something else. That impulsive behavior will often get them in trouble, right? So dealing with instant gratification is definitely one of the behavioral things that you want to do. How do I deal with this instant gratification? How do I deal with this impulsive behavior? A lot of that has to do with cognitive things. We can approach that cognitively well, depending on the person, right? They may deal with it more cognitively. They may deal with it more behaviorally, maybe a little bit of both. That's just up to the individual person. And a hospitalization may be necessary because of the suicidal or other self-injurious behaviors. So you have to be attentive to that. You have to be aware of that. You should never second guess suicidal comments, right? It's not our place to decide whether those are true or not. That's when you call the mental health deputies and put them in an inpatient setting, and they'll discover whether they're true in the next 2 or 3 days. So it's not up to us to do that. But if you think the person is borderline, do not ever, especially, what I'm saying is we don't ever take it for granted, but especially if it's borderline, realizing that suicide is a diagnostic criteria for that. Make sure you take that seriously. Pharmacological treatments, remember that these deal with different aspects of it, that they don't really, it's not a treatment for borderline personality disorder. It's a personality disorder, right? But there may be things that we can deal with. The impulsivity, sometimes those help. Mood stabilizers, things like this, oftentimes those sort of work. That affective instability, so stabilizing that. If there's some psychosis, remember that tends to be transitory anyway, but some of the medications can be used. SSRIs generally preferred over other antidepressants. They reduce that impulsivity, they reduce aggression, and less likely than many of the other psychoactive drugs to lead to suicidality. Remember that anytime we're taking psychiatric meds, the side effect of many of them is suicide, right? So if you're dealing with borderline personality disorder, that's something that you definitely want to take into consideration. Not that we'll be prescribing those, but somebody else will be prescribing those. But just to remember that if they come into session and tell you, no, I started on this particular psychiatric med, and you happen to know that suicidality is a side effect of that, then just be aware of it, right? So you may have to look closer at something like that. Low dose neuroleptics, risperidone, especially effective in short term for the psychotic stuff. But remember, those are transient anyway. So, naltrexone may reduce some of the dissociative symptoms in a small number of patients. Once again, what's the wisdom of using pharmacology on something that's a personality disorder? Probably the best thing to use it for is as we looked at, maybe the urges, right? That to curtail that impulsivity and aggression that can go on. That can be very useful there. Not that anybody here is probably going to be prescribing anyway, but once again, something to be aware of if they come and tell you, hey, I'm on this, this is what's going on. Okay, all right. Fun little thing we do here when we have sometimes is that borderline personality disorder in popular culture, okay? And this is a wonderful one right here, that Carrie Underwood song, Before He Cheats. That is about borderline personality disorder. Now, in general, country music would be a lot less if it didn't have a lot to do with borderline personality disorder. But this song especially, this is it right here. If you've never heard it before, then there's a link to it. If you have heard it, you know what I'm talking about. But this is a woman. Remember, borderline is the borderline between neuroses and psychoses. Neurotic builds castles in the air, psychotic lives in them. Okay, so now the song is Before He Cheats. Before he cheats, right? Not that he has. Okay, and if you listen to the words to the song, he's probably in there doing this. He's probably in there doing that. We don't know what the poor guy's doing. The poor guy's in there having a beer with his buddies, as far as we know, and as far as she knows. But she has created this situation in her head where he's probably in there teaching her how to shoot a combo, et cetera, et cetera. Okay, and what does she do? She she wrecks his car, right? She destroys his car. She acts on those thoughts as if they were real, when she doesn't know if they're real or they're not. Okay, we never know for the whole song. We never know. Okay, and then she justifies it by saying, might have saved the little problems for the next girl down the line, right? So that song is a perfect example of borderline personality disorder. What sort of gets you there is the response that she has to it, right? That the sort of an over-the-top response. If you've heard the song, you know what I'm talking about. If you don't, enjoy it when you can click on it. Another place this shows up is in the great Robert Lindner, the psychiatrist, in his book, The 50-Minute Hour. There's one vignette in there that is about borderline. Now, he does not diagnose it as borderline. I'm not sure the borderline diagnosis existed in 55. I'd have to look it back up again. I looked for the book. I had the 50-Minute Hour. I've read it. It's around here somewhere, but I couldn't find it, so I can't give you the name of the vignette. I don't remember which one it is, but it's one in particular. If you read it or have read it, you'll know which one it is. And this woman presents with bulimia, okay? But she jerks him all over the place. I'm surprised he wrote about it. I'm surprised he put it in his book. Because she jerks him all over the place, but the vignette ends when he rushes over to her house. The suicidality is a part of it. So he rushes over to her apartment and then achieves in that wonderful moment, achieves transference. Now you have to remember, Lindner is a psychoanalyst, right? So he's very Freudian. So he achieved transference. So he did his psychiatric duty there. We know that insight does not change behavior, so I'm not sure what actually happened to the girl after that, to the woman after that. But I would have been ashamed to put it in the book. But because he achieved transference, I guess he did his job, and they worked on it after that. But that, whatever that is, and remember, I can't remember what the vignette is, what the name of it is, but it's a good read. You can read that. Remember Robert Linder from the case, one of the cases in the 50-minute hour. He also wrote Rebel Without a Cause. Okay, that's the same guy, Robert Linder, the psychiatrist, who wrote Rebel Without a Cause, the great movie with James Dean, Sal Mineo. That you can watch the movie, you can read the book, or read the 50-minute hour. All good. But that one vignette in the 50-minute hour had to do with, we today would diagnose that as borderline personality disorder. And it's a good example of why you do not treat it in isolation. Okay, why you want a treatment team working on this and not just you. A couple of movies out there. A Girl Interrupted. The main character in that was diagnosed with borderline personality disorder. Same thing in Fatal Attraction. She was diagnosed with borderline personality disorder. Most people who who suffer from borderline personality disorder don't like Fatal Attraction because they say it's not a good representation. Let me assure you that it can go there. Okay, now that would be the far end of that. Okay, that would be the far pole of that, but it can get there. Let me assure you. Don't take it once again as that, we're not going to diagnose based on a movie. Okay, but those characteristics can definitely get there. You can watch the movie, look at the diagnostic characteristics, see what part of it you see. Now, as with many of the others, a lot of the, if you get online and Google borderline personality movies or something like that, you're going to come up with a lot of things that don't have really to do with borderline, but they'll say, well, this particular characteristic of borderline, well, I might have that particular characteristic, right? That is, I can't say anything about borderline personality just because of that one characteristic, right? Because sometimes I get my hair on fire about things, right? Sometimes I go off the deep end and use some thinking orders and what have you. So a lot of the movies and things, they'll say, well, this particular thing, but there aren't really. I include these because the characters were diagnosed in the movie with borderline personality and have some of those traits there that you can look at. Okay, so how can I help someone with borderline? Remember, it's a personality disorder. It'd be very difficult. I can be supportive of people in general, but the first thing I want to do is take care of myself. Okay, because if I'm dealing with somebody with borderline personality disorder, when in a professional setting is considered sort of mismanagement, if I'm doing it by myself and not doing it with other therapists, then, if you're a family member or you're, a loved one or something like that, you need to take care of yourself. Recognize that it's their problem. It's not you. Okay. It's their problem. You're not the one with the problem. It's them. Okay. But take care of yourself. If you need to get some treatment, then you get some treatment, but, for stress or whatever. But, learn about the illness. Okay, learn how it manifests itself. Learn some of the things as you look at that. If you're dealing with some of that and you look at that, you can say, yes, you sort of had an aha moment there. Okay, that's what's going on. That's the reason that they do that. There's this characteristic sort of borderline stuff. You can offer emotional support, understanding, patience, and encouragement, and understand that you may be the most loving person in the world for the next 10 minutes, and then you're out to destroy their lives. Just realize that's not you. You're doing what you can do, but that may fluctuate. Okay, vary between the extremes, right? Encourage the individual if they're not in treatment. See if you can encourage them to seek treatment for this. Encourage them to ask about family therapy. Once again, if they're an adult and and they're willing to go to therapy and you're willing to do family systems therapy, then have them ask about that. Set firm limits. Okay, set firm limits and do not waver. Do not waver on these things. Set firm limits. Maintain strict choices and consequences. If you do this, this is what will happen. Now, this is where oftentimes the suicidal threats come in. oh, well, because of this, I'm going to kill my, well, I'm going to call 911 and let them know, but the structure is not going to change. The consequence for the choice you made is what it is. If you're suicidal, I'm going to call, I'm going to get you some help, but the choice isn't going to change. I'm not going to give in. I'm not going to break that. Oftentimes that's very difficult for people to do, but you got to do it. Don't be afraid to call 911. Okay. If they threaten suicide, you know, you're not a treatment professional. Okay. Get somebody there who is. Call 911, call the mental health deputies, because you're concerned about their patient, because if they are borderline, it's a very real risk that they will engage in suicidal behavior. Okay. All right. If you need some support, more support, there are warm lines out there. There are places called warm lines if you've never heard of them. This is one for Mental Health Americas that was there, and then the one in orange, that's the Austin one. The state of Texas has a list of them, but those, you know, you can call the Mental Health America warm line, and they'll either talk to you or connect you with somebody closer to where you are. But if you just need to talk about what's going on, if you're having to deal with this and you need some help, then call and talk to them. It's not a crisis line. It's not a hotline. It's a warm line. People are there to talk. You know, you talk, we listen. There it is. Non-crisis warm line. So if you need to call somebody, please do that. Talk to them and get some assistance. If you need a little more, if you want some referral to treatment or whatever, SAMHSA has their helpline. That's their national number there. It's in English and Spanish. So just give them a call and they can offer some support as well. Okay, that's it. That's all I've got for this. Very intense subject for if you have to deal with it, you know that. Okay, questions? See,
there's a few of them, and I was going to try to help you get to the in the comments. They're very late on. It starts at 2 minutes and 32 seconds for you.
Okay, 2 minutes. Okay, 31, 32.
I'm sorry. Yeah. Or two. Yeah, that's right.
Yeah. Would it be possible to ask the question in private? Sure. You know what? I forgot to include that slide again.
I will.
Marty, can you put my email in the chat, please?
I will. Yes.
Okay.
And then it goes down from there.
Okay. The family's been trained, indeed. I mean, that's what happens. Sister can't have relationships with her. She wants to have a relationship with me. Yeah, I mean, you may have to just tell her, right? Just be straightforward with that. Subtlety does not work here. Okay, because what's she going to do if you're subtle? She's going to make up stories and then act as if those are true, right? So be straightforward with that. If you think you can create a structure where you feel safe, then you can go do that. Just inform her that this is the structure. This is the only way that I can deal with you is with this structure. If you break the structure, then this is what's going to happen. We're going to go away. We're not going to have this, etc. So yeah, so I would be very straightforward with this. Subtlety will do you no good. Okay, be very straightforward, but also if you can create a structure that helps you feel safe, then you can do that as well. Amy Winehouse, I'm not sure. Of course, she did end up dying from. So addiction often presents as BPD. What we see is that people with borderline personality often show up in substance use treatment, okay? And that addiction is part of the suicidality. Now, they're not trying to kill themselves, so I don't know that I would classify it as number 5, right? But it may go in number 4, right? So they engage in this impulsive behavior, such as substance use, which becomes addiction. And so, you know, they may, you know, jails, institutions, death is the progression of that. So that may, and, you know, we're talking about Amy Winehouse, and that's how it showed up sort of with her, right? With her alcoholism and what have you. So, you know, she wasn't trying to kill herself as far as I know, but that's sort of what happened because of it. So what we see, once again, like I said, is that people with borderline personality often also struggle with something like addiction. So yeah, it can, yeah, that can be, you can diagnose both substance use disorder and borderline personality disorder. It comes up as a coping mechanism. Sure, oftentimes that does. Oftentimes for other reasons, right? That may be criteria number 4. 5 will come up in and of itself as substance use or addiction. But yeah, you can diagnose both of those. Oh yeah, before he cheats, yeah. Listen to it again. Look at the criteria. Listen to it again. Can it be transmitted from parent to child? How to prevent or minimize maladaptive behaviors? The prevalence is, it's more common in first-degree relatives. So if I have, if for example, my mother was diagnosed as borderline personality, the chances are greater that I could be diagnosed with that, as opposed to if she wasn't, right? If I have no first-degree relative, then the chances are less that I'm going to be diagnosed as that. But remember what we're talking about when we talk about borderline. We're talking about ways people interrelate and think about other things. So when we're looking at this, we're looking at thinking and behaviors, and where are behaviors learned? Primarily, they're learned from the family. If I grow up in a family and I see people behave in this way, and then I try it and it works for me, and that's the only reason I develop a pattern of behaviors, because it works for me in some way, then that's what I'm going to adopt. So yes, yes, indeed, we see that in families because that's just what I see as I'm growing up. So I can do that. If the question is there something we can point to, some lesion in the brain that causes this or something like that? No. Okay, there isn't. So what I'm doing is I'm picking this up as a behavior. I'm learning this it's a learned behavior is how I'm picking it up. It's not caused by a brain malfunction, which is why there's no pharmacological treatment for it, right? The pharmacological treatments deal with symptoms of this. They deal with the anxiety, or they deal with the impulsivity of this. They don't deal with it as in of itself as a brain disorder. I hope that answered your question.
The 988 hotline, I don't know, is that just gone national, I think? But the 988 lifeline for crisis and suicide, I know, is up and running. So the 988 is a good emergency number for you to have online.
Here's one. As I understand, BPD is often rooted in early trauma, in crews being raised by someone with certainly the raised by someone, that's where the first degree relative comes in. That's where we can see the behavior that I'm learning from the behavior. As far as it being rooted in trauma, that is false. Okay, we used to think that it was. The new research shows that there's really no evidence to support that it's rooted in early trauma. That used to be something that we thought. So you may actually, if you're reading some older things, you may actually be reading that. You could read that, but these days what we're finding is that the research does not support that it's caused by early trauma.
Wow.
So don't link those two things. Other than being raised by someone with BPD, I mean that can be a traumatic experience. But what I'm learning from that is I'm learning it's not the trauma; it's that I'm learning those behaviors as I see it.
Wow.
How do I know if I have the disorder? Go to someone who's able to diagnose. Go to a psychiatrist. Go to a professional counselor, social worker, someone who can diagnose that disorder. Psychologist, someone who can diagnose it. That's how you know. Does EMDR help with BPD? I can imagine that there would be situations where it would help me calm down and process some of the things that I may be looking at. But that's what EMDR does anyway, right? EMDR, that eye movement desensitization and reprocessing, what it does is that it helps me to calm down so that I can talk about and process trauma in my life. Now, because BPD isn't necessarily related to trauma, it doesn't mean that those people don't have trauma, right? When I engage in relationships, especially things that, you know, the substance use, the promiscuous sex, the dangerous, these sorts of things, I can find myself in situations where I've indeed experienced trauma. So as I'm dealing with that, then the EMDR may help me deal with that trauma in and of itself, or it may help me just relax so I can process some things as I go along. Is lying pretty common with this diagnosis? I want to say yes, but at the same time, remember that this is how people see things, right? Remember that how it got its name, borderline between neuroses and psychoses. I'm not telling you a lie per se, although I've known plenty of people who had this who lied, right? That's the reason I make that caveat. But at the same time, I think this is real, even though it may not be real. You know, I think he's cheating. Well, he's probably yeah. So it can be. It's also common with antisocial personality disorder as well, that lying part. So
and that's coming up. We're doing that next month, just so you know. Antisocial personality disorder is coming late in August.
A person abused by a narcissist can present as BPD. Remember, I just want to stress this once again, that the abuse, the trauma doesn't have to be there for BPD. In fact, we've found that there's no really relationship to that. But if I've known people with narcissistic parents, I've known many people with narcissistic parents, they didn't present as bipolar. As borderline. They didn't present as borderline personality disorder because they were raised by narcissists. In fact, I can't think of one borderline personality patient who actually had narcissistic parents. That doesn't mean they don't exist. This is just from my experience. Certainly, narcissistic personality disorder is another personality disorder that people can certainly show up with. I think what we see the most is that the parent is borderline. Okay. And you didn't say parent, you just said a person who's abused by a narcissist could present as BPD. Some of the things, okay, I think I see your question now. Sorry. Takes me a minute sometimes. Could present as having some of the behaviors that I adopt on having to deal with a narcissist could present as, if somebody was looking, they could say, oh, well, that seems to be borderline personality behavior. But I do that as an adaptive thing because I've had to deal with a narcissist, okay, in my life at some point. So yes, some of the things could present as characteristics of it. You're probably not going to get a diagnosis of it, though. It could present as borderline characteristics, but probably not borderline personality.
There's also, and I know they're pointing out, and I've had them up, there's also several questions in the Q&A as well.
Okay. All right, let's see. Connected with antisocial personality, not in and of itself. Like I said, sometimes female antisocials tend to be more misdiagnosed as borderline when they're actually antisocial, but not in and of themselves. And you can be both. You can have both. Both of them are personality disorders. Okay. How many people overcome borderline person? I don't know any statistics on that. Yeah. I mean, I've worked I've worked with people who've made dramatic changes in their lives, and that's what we're looking for, right? Statistically, how many people get over it? I'm not sure what, overcome BPD. I'm not sure what that means. Does it means I'm no longer diagnosed? Well, once I get a diagnosis, I'm always diagnosed that. I just may be in remission. But, how many people are able to deal with these problems and go on to live normal, effective lives and develop relationships with people in their life? Many, okay, many, okay. Or any free resources if you don't have insurance? Marty, I'm going to leave that one to you.
Yeah, we'll have to look.
Okay, and now let me look in the Q&A. Is BPD associated with race? Not so much, not so much. You can look in the DSM-5 TR. It'll tell you that, but there's not really an association there. Learned or inherited? Learned. Okay, there is a genetic first degree things, but where are they gonna, take them out of that situation and put them in another situation? Is it gonna manifest itself? I'm going on the learn side. Favorite person? Okay, if you happen to be the favorite person, you're lucky. You may have not become the very unfavorite person. The hated person at the same time. But yeah, if you're feeling that maybe you're that favorite person and the person you're having to deal with can be diagnosed with borderline personality disorder. And you unfavorite them without cutting each other out of your lives. From the borderline standpoint, remember that what they're struggling with is black and white thinking. So you tend to be either the favorite or the unfavorite. If they do work on that, if they're working on it, then maybe they can reach that gray area. That can certainly occur, especially if they're older, right? Once again, 30s, 40s, these characteristics tend to mute somewhat. Not that they ever go away, but they tend to be more muted in later life. So sure, if I understand your question correctly, then it's possible. Median age in the community. It presents from from childhood, adolescence, all the way to adulthood. How that stacks up, I'd have to look back at the statistics on that to see exactly how that stacks up. But it's not more common. Well, no, if I could say that, I could give you the statistics, couldn't I? But I'm not sure. I don't know. I'd have to look it up. 5 out of 9 criteria, yes. 33 with 2 kids. Well, there you go. Yeah. Yeah. So at about 33, right? Hopefully those sort of characteristics have become muted. Yeah, if she's not in treatment, then yeah, she's gonna accuse you. She's gonna engage in those behaviors that we've looked at. I would suggest, make sure you take care of yourself, give the kids all the love and attention that they can stand. That's good for them. But then set strict boundaries with her. Set strict boundaries. Do not go past them. Being able to set boundaries to do that. That would be the best for your relationship with her. Can I relate? Can I more on that? Well, I could, but I'm going to avoid philosophy today. We might get that in another. So we're already over time. So, how do you select proper treatment? Doctor, DBT is the treatment. That's the only evidence-based practice specifically for borderline personality. So if you want to find a therapist, then a psychologist or a professional counselor, something along there, I would make sure that they probably worked with this disorder before. Would be something. Try to see if they work in conjunction with a treatment team instead of in isolation, and make sure that they use DBT, dialectic behavior therapy. If they're on the couch, they don't need to be there, because you're using a psychoanalyst, and that's not going to help them at all.
Doctor, do you treat this, and do you have a team of people that you work with on this?
I have treated it in the past. I don't treat it now specifically as that. It shows up when I'm treating other things and I recognize it. And most of the things I do are cognitive behavioral anyway. So I'm just aware of it, and I'm aware. I set very good boundaries on, I'm not going to go there. I might make the suggestion that they see someone else. I've done that before. As you're seeing me for substance use, that's fine, but maybe you want to talk to somebody else about these other characteristics. Everything we do is, like I said, pretty much cognitive behavioral. So the skills that they learn and everything else they can use. And we may talk about, substance use is an interesting thing, because it incorporates all of someone's life. You can't separate that out. So you find that if you work with substance use, that you're getting everything else that goes along with it. But so like I said, I'll suggest that they get somebody else. I won't work on it specifically as that, but I may suggest some of the cognitive behavioral techniques that'll help them as they move on, and suggest that they see somebody else. But no, outside of, do I deal with people who have it? Yes. Do I treat it specifically? No. Run in families, once again, first degree relatives tend to have more of a prevalence of it, and tends to improve, tends to become muted after, and muted from your hair on fire is, not, it's just smoldering now, right? But it does, 30s and 40s, those things tend to become muted, if they don't kill themselves before they get there, right? And remember, if how this shows up is one of those things like substance abuse itself has a lot of different ways to kill you, okay? Doesn't have to be from the substance itself. I can be so drunk that I don't notice the house is on fire and I burn up in it. I've known that to happen as well. So that has a lot of ways to kill you in and of itself. Once again, that would be criteria 4 instead of criteria 5, but yeah. It's quite possible, based on someone's description of their mother, that and knowing that they're borderline and they describe their mother, and when I, if I say, it sounds like you and your mother are a whole lot alike, I'm probably making that diagnosis in my head, that's where that comes from. Yeah, I'm not sure. Accusing other people of diagnosing. This is why I don't really diagnose, right? I may diagnose substance use, but anything other than that, I don't really diagnose. I find it unproductive generally, unless you're paying by insurance. But I don't take insurance, so I'm able to get by with that. But if somebody's paying insurance, they have to diagnose. Tarrant County, I'm not sure. I'm in Austin.
You can,
but I'm sure you have them.
Yeah, there's no doubt. But you can send me that question. I'll get it to the right people if you'll email that to me.
Okay. Okay. Well, hopefully that gave you some information about borderline, and a little bit of what it's like to not only have to deal with that, which is oftentimes where people, and the reason I focus on that is because that's why you're here, right? At this particular webinar, is because you may have to deal with that and what have you. So that's what I tend to focus on. But remember, it's not pleasant looking out of somebody else's eyes who has it. And I mean, can you imagine every relationship in your life just seems, it's just in conflict all the time. If we try to practice a little bit of empathy there, we can see that it's not a pleasant place to be if you're struggling with that. And once again, I know as if you're in a family of someone or what have you, that you feel like you're stressed, you feel like you have really had it with this. Remember what they're going through, right? Remember, try to sort of see it through their eyes, and it's not a pleasant picture of what you're looking out at, especially when you're so miserable in your life because you don't have any real meaningful relationships. So because you push all those people away, and then you're left with nobody. So it's certainly a disorder where we want to be empathetic toward those people, but set strict boundaries.
Could we advance to the next slide real quick? I just want to, I'm not going to go over the CEUs. I went over them once with everybody. You've had them up for quite some time, but I just want to make sure my loved one is struggling with substance use disorder. How can I help? We're going to address that on August 10th. I think it's the 24th or of August. We talk about the, oh shoot.
Antisocial.
Thank you, antisocial disorder. And so just so you know, those flyers will come out with a follow-up email. Doctor, once again, thank you so much. Incredible information.
My pleasure. Thank you for
all,
having me.
Absolutely. Thank you all for joining us. Look for the follow-up email or the pop-up survey to complete as you log out. And thanks you all for joining us. You all have a great day.